Hi, this is Dr. Abhishek, and today I will be talking about transfusion reactions in neonatal and pediatric group of patients. So, in this talk, I will just cover and pertain myself to how the transfusion reactions are different in neonates from other groups, that is adults. And I will not be going to repeat other definitions or with respect to the topic. So first thing is why neonates and children are different in which way in comparison to adults with respect to the adverse transfusion reactions. One is the age-adapted adverse transfusion reactions definitions and criteria are not available particularly for neonates and pediatrics. They are vulnerable due to their physiological differences or complex administration of the blood products, and also the specific blood components required in pediatric and neonate is different from those in adults. The indications are different, and even the blood product type that is used with regard to the dosage, the infusion rate, the monitoring that is required, and the triggers for transfusion are different from the adults. And also, in transfusing a child or a neonate, you should keep in mind the long-term development, particularly in terms of neurocognitive development of the infants. So, what do we know about how much the transfusion requirement is? It is known that 90% of extremely low birth weight infants weighing less than 1000 grams are estimated to receive at least one red cell transfusion during a neonatal intensive care unit stay. And in very low birth weight infants, it's around 60% during their stay. So, what are the data that is available? This is one recently come up report from Hemovigilance of China, which says transfusion reactions were in children were concentrated particularly in the diseases of the blood system, that is leukemias or thalassemia, or probably because of their repeated requirement for transfusion. 80% of the children with transfusion reactions actually had a previous history of transfusion, and transfusion reactions were most commonly associated with platelets, followed by plasma, that followed by RBC transfusion. What about the Indian reports? There are two reports, one from January 2013 to 2016 and the other one from 2016 to 2017, both published. And this shows actually the categorically, actually there is no denominator here, so it's very difficult to tell about the percentage or the rate, but we can grossly see that it's about around 10% of those reactions reported in the adults. The same way, if we come to the 2016-17 to 17, even there is particular differentiation into less than 12 years and more than 12 to 18 years. But however, still we can notice that it's almost marginally increased, but almost like 10% of the adults. This is from the short report, which says that 8.6% of all the transfusion reactions that were reported were among the less than 18 years old, which almost similar to our hemovigilance report. And in that, 31% of the reactions happened in infants less than 1 year. And 56% of these neonates were actually less than 28 days old. Short reports 2008 to 18, that in 10 years of report, pediatric versus adult showed that there is actually, in contrast, disproportionately high number of reports in the pediatrics. But probably we should note here that they have actually taken the incorrect blood transfused and the specific requirements not met also as the adverse event. So hence their report says that it is higher than the adult. 2/3 of the pediatric reports were actually just errors which could have been preventable. They could have been avoidable or delayed or even under or over transfusion. Febrile, allergic, and hypotensive reactions are approximately constituted a quarter of those reactions. TACO is a smaller percentage of pediatric reports when compared to the adults. Pediatric patients were less likely, that is almost 0.63 times less likely to receive a transfusion than adults overall. Pediatric patients had a significantly higher incidence of transfusion reactions associated with platelet transfusion. So this is the estimated incidence, that is around per 10,000 units issued. In pediatrics, that is 18 years to 1 year, the estimated incidence was around 18, whereas in adults it was around 13. And in neonates especially, that is the wrong components transfused or for a wrong indication was the most common, which was around 82%, and it was noted in 37%, 37 incidents per 10,000 units transfused. Majority were allergic, and also volume overload was common in infants. So we'll go into each of these reactions and see how in pediatrics it is different. I will not go into mechanism, which is already spoken by most of the speakers. We'll just see how it is different in pediatric population as such. Coming to hemolytic transfusion reaction, which is by far, of course, not the commonest, but very dangerous in adults. It's supposed to be less of a common problem in neonates or the infants. The reason is that maternal isohemagglutinates are present only occasionally in the first 2 months of life. Okay, and the infant alloantibodies are rarely formed before 6 months of age. So these two reasons could be the reason why we don't see much of hemolytic or immune-mediated reactions, hemolytic reactions. And also, due to the probable involvement of what is known as PANTs or pediatric antibody tests that regularly happen, which almost eliminates the hemolytic transfusion reaction. Components are screened for clinically significant blood group antibodies, including the high titer A and anti-B, and an indirect test is performed, and which is called as the PANTs or the pediatric antibody tests. Coming to the TTIs, given their small volume, neonates are often transfused with multiple small aliquots, probably from the multiple donors, and hence they could be at a higher risk for acquiring a transfusion-transmitted infection. However, by dedicated units, this can be brought down. And also sterile connecting device. How sterile connecting device is usually what happens whenever we open a unit of blood in the open system. If we don't use it within 24 hours, that blood is either discarded or given off to a patient. So this blood unit is generally not available for a repeat transfusion, if at all the same infant needs. With sterile connecting device, that could be avoided, and dedicated units can be continuously aliquoted from and used, avoiding the exposure of multiple donors. Also, PD packs which are available can help us where blood is aliquoted at the collection itself, so that there is no problem with associated with the aliquoting at the issue site. A dedicated donor program can also be utilized. And also, infants have high risk of CMV, especially the low birth weight infants who are born to seronegative mothers. FNHTR and allergic reactions are by far the most common transfusion reactions, even in neonates and pediatrics. Why it is so? Probably because of their smaller body. We all know that higher dose of pyrogenic cytokines in the blood product, it is usually the dose dependent. More the cytokines in the blood product, more will be the chances of. That's why we all say that hemolytic, non-hemolytic febrile reactions can actually be reduced by reducing the flow rate. And also, we know that allergic reactions are usually due to allergens present in the blood products, usually the plasma products and other things. And since of the smaller body and a higher dose of allergens in blood products, it's pediatric patients may be amenable for more commonly for allergic reactions. Even undiagnosed IgA deficiency can be a risk factor. Coming to metabolic transfusion reactions, hyperkalemia is very particular for pediatrics. The problem is because of the impaired renal function due to either disease or prematurity of the kidney. And also because of the large volume and rapid transfusions that happens because of their size. And this especially when administered to a central or intracardiac line, where high concentration of potassium are being rapidly delivered to the heart without first being filtered through the kidneys, can lead to cardiac arrest and death. How do you prevent them? Washing, calcium boluses upfront, albumin or glucose could also be utilized. And the red cells, if we have to be irradiated, they have to be done as close to the time of transfusion as possible, especially for large volume transfusion in infants and kids, that is when you transfuse more than 20 ml per kg. Hypothermia is a very, again, a common transfusion reaction that can be noticed in pediatric patient and infants. The susceptibility in them is due to decreased body fat, an immature epidermal barrier, higher surface area to weight ratio. Who are the people at risk? The infants on ECMO, undergoing exchange transfusion or cardiac surgery or trauma. It is known that even blood products at room temperature have been shown to decrease an infant's core body temperature by 0.7 to 2.5 degree. So whenever you infuse cold blood direct from the refrigerator, the chances of neonates going into this hypothermic reactions are more common. So prevention is very simple. Use dedicated blood warmers. What about platelet refractoriness? We all know that all immunological, as I said, all immunological reactions are comparatively lesser in pediatric and infants when compared to the adults. And the incidence of alloimmunization and platelet refractoriness appears to be lower in children than in comparable adult population for the same reason. Trally, could be very lethal or severe reaction, but however, again, it is said that trally is slightly common, less common in pediatric and infant, but they have said that there are two peaks for trally that has noted, one in infants less than 1 year, and the second peak in ones who are more than 14 years. The other debates or reasons given why trally probably is less commoner is probably because of more difficult to differentiate from other pulmonary pathologies in this population, and the definition that is available is also not suitable for pediatrics usage. What about TACO? Again, it is known to be more common in children less than 3 years. And the other, the TACO definition that is used to define this transfusion reaction is either most commonly the CDC one or the ISBT definition. But the problem is they do not define cutoff for age adapted vital sign values. They're defined for adults only. And these definitions actually ignore the effect of critical illness that can per se influence vital signs, especially in this group of people. A peculiar and to be noted transfusion reaction in infants is transfusion associated necrotizing enterocolitis called as TANAC or even TRAGI, that is transfusion related acute gut injury. Happens because of exposure to biologically active mediators such as free hemoglobin, increased cytokines, and broken red cell fragments within the transfused blood, which triggers an immunological response within the intestinal mucosa. Altered angiogenesis within the intestine due to platelet activating factor acetyl hydrolase also been described to be causative or associated. And the one of the more common thing that is cited is the reperfusion associated with transfusion that happens to the gut. So how to avoid them? TANAC is associated with an increased need for surgical intervention and prolonged hospitalization. The risk factors are prematurity, low birth weight, and hypoxic ischemic events. So for prevention or suggestions for prevention is withhold feeds during the transfusion so that it counteracts the postprandial alteration in blood flow that happens. That is, when you give transfusion, avoid giving feeds so that the flow to the gut is not diverted. Provide washed red cells to all neonates with necrotizing enterocolitis, because it is noted that complement-dependent antibodies can cause lysis of the neon antigen labeled red cells. So these are few suggestions which may help. Coming to TAGVHD, very rare but almost near fatal event that can happen. Commonly noted in immunocompromised patients, extreme premature infants, neonatal alloimmune thrombocytopenia patients, or patients on ECMO. Prevention is simple, use irradiated blood. So to summarize, adverse transfusion reaction in transfused children differ from those in adults in both type and frequency. For the most commonly reported adverse transfusion reactions, the prevalence is higher in children than in adults, with the exception of RBC alloimmunization, excluding patients with thalassemia or sickle cell diseases. Allergic reactions are frequently reported, and platelet concentrates is the most commonly implicated blood product. Numerous difficulties remain, and several modifications are needed to adopt and standardize pediatric adverse transfusion reaction definitions as well as the criteria, with the aim to improving both studies as well as reporting. Thank you.